Hello, this is Maher Abbas from Dubai, the United Arab Emirates, and today I will be speaking on anal fistula, the causes of operative failure. I would like to thank my dear friend and colleague, Dr. Padma from Moscow, for the very kind invitation to speak at your meeting. I've known Padma now for over 20 years, since my days at the Cleveland Clinic. Now, Albert Einstein said that the question may be the same, but the answers have changed. And when it comes to the treatment of anal fistula surgery, this is very, very true and very evident, as you would see from the data that I will be presenting to you today in my talk. Today, we will be talking about causes of operative failure, but another way to ask the question is, what are the predictors of outcome, predictors of success or failure when it comes to the treatment of anal fistula surgery? Now, why do we care about predictors of outcome? Obviously, as surgeons who treat conditions such as anal fistula, we always want to try to pick the right operation for the right patient. We would like to optimize the result of any surgical intervention we undertake, at the same time avoiding failures and complication postoperatively. And when it comes to anal fistula, we always ask ourselves, what can we do to get rid of the disease, to minimize any potential postoperative complication? Obviously, we want to preserve the function of the anus by preserving the continence. And finally, we would like to minimize the risk of recurrent disease. Now, what is the difficulty with the anal fistula? The data in the literature is all over. When you look at this slide, it summarizes the success rate of endorectal advancement flap for anal fistula. You see here many series reported starting in the 1980s to 2010, including my series that I reported in 2008. What you see here, success rate varies anywhere from 33 to 100%. In my own series was 83%. And when we look, for instance, for the development of new incontinence after such operation, the incontinence rate has been reported anywhere from 0 up to 35%. In my own series, it was 8%. So we see a huge range of outcome reported in the literature. And finally, if we look at an operation such as the anal fistula plug, the study published in 2010 in Disease of Colon Rectum reported the result of the plug over a 4-year period. As you see here, initially, when reported around 2006, success rate was from very few studies was reported very high, 80% or more. But as more and more data start being generated, we see a widespread of outcome and success anywhere from the 15% up to 90%. So a very large variation of reported result. And the question is, why do we see such variation in the literature? And are they predictors that can predict why some series have had higher success rate and why some have had lower success rate? And when we look at anal fistula surgery, the outcome measures are the one listed inside the pyramid. Obviously, we are interested in a healing rate, complication rate, recurrence, and continence. And in general, there are 3 major buckets of predictors of outcome. These would be preoperative factors, which we will discuss, operative factors, things that happen in the operating room, and finally, postoperative factors. And all combined, they will determine these 4 outcome measures in the middle. Now, in terms of preoperative factors, obviously the fistula characteristics are very important. So the etiology of the fistula, what caused it in the first place, what type of fistula it is, and has the patient had previous intervention for the anal fistula. We look at patient-related characteristics such as body habitus, weight, obesity, smoking, baseline continence function in the patient. We also look at intraoperative factors related to the surgeon, the choice of the operation picked by an individual surgeon for individual patient, technical issues, how the operation is conducted, and what are the things we do in the operating room, and things we do find in terms of intraoperative findings, which we will discuss a little bit later in this talk. And finally, postoperative outcome is determined by things like complication. If you develop a septic complication or infection after anal fistula surgery, there's a higher likelihood that the repair will fail. Now, in terms of the etiology of the fistula, these two studies are from Cleveland Clinic, Ohio, and Florida, looking at 193 endorectal advancement flap. And when we compare patients with Crohn's disease versus those without Crohn's disease, clearly the failure rate is much higher in patients with Crohn's disease, 50% versus 23% in one series, and 57 versus 33% in another series. So the etiology of the fistula makes a large difference. And the type of fistula in this study from Cleveland Clinic in Florida, looking at 125 rectovaginal fistulas that had had various operation. Again, patients who had Crohn's disease-related rectovaginal fistula had a much higher recurrence rate, climbing to approximately 56%. Compare patient who had cryptoglandular disease for the fistula, who had 16% recurrence rate. And obviously, the fistula type, whether it's a rectovaginal or anal, will determine the outcome. Failure rate for rectovaginal fistula is much higher. In the study from Cleveland Clinic, Ohio, failure rate was 57% versus 24% in patients who had anal fistula without vaginal involvement. The fistula length may be a determinant of outcome. This study looked at the 41 patients who underwent the placement of an anal fistula plug. When the author measured the tract at less than 4 centimeters versus patient who had a tract greater than 4 centimeters, the longer the tract, the lower the failure rate, 39% failure rate compared to 79% if the tract was shorter. And fistula classification is important. When we look at the study from Spain, the more complex the fistula is in terms of muscular involvement, the higher the recurrence rate. Intersphincteric fistula in the study had 2.6% recurrence rate. However, patients who had suprasphincteric or extrasphincteric fistulas had approximately 30% failure rate. And in my own studies, from Los Angeles, looking at 179 patients, when I looked at the impact of the fistula classification on function, postoperative function, patient who had either low transsphincteric, intersphincteric, or subcutaneous fistula had 10% or less new incontinence rate. However, those who had high transsphincteric or suprasphincteric fistula, the incontinence rate climbed to 40 and 55%. Similarly, the study from Spain mirrored my own result when they looked at the intersphincteric fistula, 5.9%, but when they start looking at suprasphincteric or extrasphincteric fistulas, the new incontinence rate was in the 40% range. So clearly, the classification of fistula will impact the outcome of the intervention. And in this study from Germany, when they looked again at the incontinence rate, suprasphincteric fistula seemed to carry the highest rate of incontinence, about 43% compared to 21% in patients with transsphincteric fistula. Now, does a previous intervention impact the result? Ellis Neal, when he was at the University of Alabama, looked at 95 flap, both endorectal and anodermal flap. If a patient had no prior repair, the failure rate or recurrence rate was 23%. However, if they've had a previous intervention for anal fistula, that climbed to 43%. And similarly, in the study from the Cleveland Clinic, looking at 125 patients with rectovaginal fistula, if patient had no prior repair, the recurrence rate was 30%. However, if they had 3 or more repair, the failure rate was 50% or more. And this was also documented by this study on endorectal advancement flap from the Netherlands, 5-year series looking at 44 patients. If patient had 1 or no prior repair, the failure rate was 13%. If they've been operated 2 or more times, the failure rate climbed to 50% or more. And not only does the success or failure rate get impacted by the prior repair, but also the incontinence rate is higher in patients who had a prior repair. In this study from, again, Cleveland Clinic, Florida, it was 19% versus 5.3%. Now, does age impact outcome? In my own series from Los Angeles, when I looked at baseline incontinence in all the patients, 7.3%. postoperative incontinence developed in 12.4% of patients who were younger than 45 years of age. But if they were older than 45 years of age, that incontinence rate almost doubled to 23.3%. So clearly, age will determine function after surgery. Obesity, my colleague and friend Oliver Schwander from Germany looked at 220 endorectal advancement flap, a very impressive series. This data was accumulated over 2 years. Overall success rate was 82% in his series, and he compared patients who had a BMI of 30 or less or greater than 30. And clearly, the recurrence rate doubled in patients who were obese with a BMI of greater than 30, 28% versus 14%. In addition, the likelihood for needing reoperation was much greater if they were obese, 73% versus 52%. And it was an independent predictive factor of success or failure in his study. Smoking does impact the outcome. In this study from the Netherlands, from Zimmerman, 105 endorectal advancement flap, the smokers had a healing rate of 60%, which was diminished compared to non-smokers, 79%. In a subsequent study by the same author, they measured physiologic oxygen concentration at the level of tissue, perianal tissue, and obviously the oxygen concentration was lower in smoker compared to non-smoker, and this was provided as one plausible explanation for why the success rate is lower in smoker. And these findings have been confirmed at a later date by Ellis from Alabama and others as well. Now, in addition to patient-related characteristics such as smoking, fistula type, obesity, the choice of operation, things we do to the patient in the operating room will determine the outcome. When we look at the series from Spain, the recurrence rate was lowest when a fistulotomy, laying open the fistula, was performed. Recurrence rate was 1.5%. However, when the hole was closed, either by suture closing, coring out, or plugging, that recurrence rate became nearly 43%. So clearly, the choice of operation will determine the outcome. And in my own study from California, the operative failure rate was lowest with fistulotomy, which was 10.1%. Endorectal advancement flap at only 15.8% failure rate. However, if an anal fistula plug was used, the failure rate was very high, 83.3%. And looking at comparison between technique, the top studies is a randomized clinical trial from Spain comparing the endorectal advancement flap to the anal fistula plug. Success rate for the flap was 87.5%. The plug, however, had a success rate of only 20%. These results have been duplicated by study from the University of California in San Francisco, where the endorectal advancement flap had nearly twice the success rate of the plug, 62 versus 34%. Now, not only the choice of operation matters and will impact whether you fail or you succeed, but how you conduct the operation is very important. This study from Austria, Vienna, looked at 54 patients who underwent the endorectal advancement flap. The overall success rate in that series was 76%. The type of flap mobilized, if you only took mucosa versus a full thickness flap, recurrence rate and incontinence rate were much higher in patients who had a mucosal based flap, 35% failure rate and recurrence rate versus 5% in patients who had a mucosal flap versus full thickness flap. And the incontinence rate was slightly higher in those who had mucosal based flap, undoubtedly related to the failure and the scarring that occurred. Now, at one point, in order to augment the result of the flap, people thought that by adding fibrin glue, closing the fistula internally with the flap, and then injecting fibrin glue through the external opening to fill the tract. Obviously, it didn't work. Two studies that looked at that, the recurrence rate was much higher when you added fibrin glue. Invariably, it failed more often, most likely related to septic complication. Recurrence rate of 56% versus 13% in one study, and 46% versus 20% in another study. So if you contemplate adding fibrin glue to the flap, don't do it because it will fail more often. And does the type of material we use for anal fistula surgery matter? Now, most of us have abandoned completely or partially abandoned the use of prosthetic material in fistulas, such as the fistula plug. But this study, looking at the early failure rate of patients who underwent the Cook surgical plug, which was the first one available on the market, compared to the Gore Bio A one, the failure rate was much higher for the Cook plug, 87.5% versus 45.5%. Now, and not only the choice of operation will impact your outcome in terms of success or failure, but it will also impact the complication rate. Again, my own data from California, looking at 179 patients who underwent fistula surgery over a 5-year period. Septic complication, fistulotomy, 4.6% develop an anal cellulitis or an abscess. The endorectal flap patient, 10.5%. The anal fistula plug had much increased rate of 33.3%. And do intraoperative findings determine outcome? Clearly, finding the internal opening at the time of your operation is very critical. The series looked at 461 simple fistulas, non-complicated fistula in the US. The recurrence rate in the study overall was 6.5%. However, if the surgeon missed the internal opening, could not find the internal opening at time of surgery, recurrence rate was greater than 50%. If a missed secondary track, the recurrence rate was 20%. So clearly very important to identify the internal opening and any secondary branches in order to eradicate the sepsis. If you go and you cannot find the internal opening, it's best to abort the patient and observe and come back another date rather than completing the operation, because you're going to create more scarring and you're going to be doomed for failure in over half of the time. The impact of the internal opening was also demonstrated in 2 large studies, one from Spain containing 279 patients, in which 7.5% of the patient internal opening could not be found. If that was the case, the likelihood for recurrence was greater than 5 times. That's the odds ratio hazard. And in University of Minnesota, studies looking at 4-year data, the internal opening could not be found in 4.3% of the cases. And the recurrence rate in those patients was 56% versus 7% if an internal opening had been found. So, ladies and gentlemen, in conclusion, I'd like to go back to the quote by Albert Einstein. The question may be the same, but unfortunately, when it comes to anal fistula surgery, there is no single answer. Anal fistula is a very complex condition. The data in the literature, scientific literature, is very heterogeneous and can be confusing, and you have to be very careful of how to interpret it when you do your own reading. I highlighted here in this talk factors that I believe do impact the outcome, such as patient-related characteristic, smoking and obesity, prior intervention on the fistula, the classification of the fistula. The more muscle, the higher the failure rate, the etiology of the fistula, were they related to inflammatory bowel disease like Crohn's disease or not, and the involvement of the vagina in women or not, rectovaginal fistula carrying a higher failure rate. So putting it all together, it would take someone like Albert Einstein to really figure out how we can predict the outcome. If you look at all the bubbles in white on the left hand side of the screen, these are basically all the patient determinant, the choice of the operation, the fistula characteristic. All these factors combined together, coupled with the type of operation we do, which is in the blue, will determine the final outcome. And I think we need to kind of move in the modern area of treating the anal fistula to an algorithmic-based model where we can incorporate all these factors to try to provide guidance for surgeons who treat anal fistula in terms of what is the best operation for an individual patient. With that, I would like to thank again Padma for the kind invitation. This past August, I visited the colorectal surgery unit, and Professor Pavlov in St. Petersburg. I really very much enjoyed my trip to Russia. I learned a lot about the greatness of Russian medicine, and I do hope to come again to Russia and engage in further dialogue and knowledge sharing and information. And I do welcome any of you who visit Dubai to come visit with me. Thank you very much.